So let me introduce our speaker tonight, who is Dr. Doug Ebersole. On mine, he's in the upper left. Doug and I met. We realized 11 years ago, at hosted by Mr. Dan Orr, at least partially hosted at the Dan Fatality Conference of 2010. And Doug and I just happened to sit next to each other and continue to do so for the 3 days of the conference. And look where it's gotten him. Now he's been stuck with me all this time. But Doug is a cardiologist in Florida, and more importantly, is not only someone who obviously has been dealing medically probably with some of the COVID stuff, but he himself is a COVID survivor. And he told me before we started he got it exactly 1 year ago today. So happy anniversary, Doug.
That's right.
So he's going to talk about just sort of diving in the COVID era. We'll take questions, like I said, at the end. I'll give the disclaimer if he's not going to, that even though he's a doctor, he's not giving you personal medical advice. Although, Doug, I've got this little mole up here with me. And so we'll do the best we can. And I think it's going to be a timely talk because if, as you probably know, today the CDC said pause on the J&J vaccine, which apparently every single state now has signed on to doing. So every day the landscape changes, and hopefully Doug can help us navigate our way through it. So Doug, the floor is yours, or I should say the computer screen is yours. Have at it.
Thank you. So I'm going to share my screen, make sure we check this ahead of time. Let's make sure this works okay. All right. Is everybody seeing that, Ken?
There we go.
Okay, got it.
Yeah.
Okay.
All good.
So thank you, Ken, for inviting me to speak here. This is my hospital and my clinic. I'm in Central Florida. I'm in a place called Lakeland, Florida. It's halfway between Tampa and Orlando, which means I'm about 2 hours south of Cave Country. I'm about 2.5 hours west of the Jupiter West Palm area, about an hour to the Gulf of Mexico, and about 4 hours to the Keys. So for kind of centrally located for diving and so forth. Probably a lot of you are probably asking, who is this guy and why is he talking to us? As Ken mentioned, I'm an interventional cardiologist here in Florida, so I make my living basically in pajamas doing video games with balloons and stents and implanting valves and plugging holes and so forth and so on. I'm also a very active diver. That's me ice diving last month, actually a month and a half ago, I guess now, in Utah. I got certified back in 1974. I teach recreationally for a multitude of agencies. I teach technically for both INTD and TDI. I'm also a cave instructor, and I've been. It's been good for me that I've been on the board of advisors for INTD, and I'm on the training advisory panel for TDI and SDI. And the RAID agency has me as their medical director. So I've had a lot of experience. Scuba diving, I do probably 130 to 150 dives a year. And because of my diving background and being an active diver, as well as being a physician, the people at Dan were nice enough to ask me to be a cardiology consultant a number of years ago. So I've been trying to do some work with them. But all that has nothing really to do as to why I'm speaking with you guys here tonight. Like Ken mentioned, I'm also a COVID-19 survivor. You'll notice I saw this today when I was going through my slides, that actually I was tested a year ago today when I became positive for COVID. That's me in my office there. So what happened to me was I was exposed to a patient in my office back in March of 2020. This was very early in the pandemic. People were being screened with temperatures and so forth, but somehow this patient made it through. He was seeing me about a totally unrelated elective procedure. But he was very, very sick appearing in my office, and actually got him admitted from my office right to the hospital, and he got admitted right to the ICU. He subsequently, it took about a week for him to get test results back. Again, it was very early in the pandemic. And then I developed symptoms about 10 days after my exposure to him, with fever to 102, non-productive cough, shaking chills, fatigue, so forth and so on. My symptoms resolved after about a week or 10 days, and this is important. I thought I was back to normal, and I think a lot of people feel they're back to normal after a week or so. But at this time in Florida, all the gyms were still closed, so I couldn't go back to the gym to exercise. So I broke out my rowing machine, figured I would do my usual 30 or 45 minutes on the rowing machine, but I was totally gassed in about 5 or 10 minutes. So while I thought I was back to normal, I clearly was not. And it took about 2 weeks to get my exercise tolerance back to normal. We'll talk a little bit about that here in a minute. More importantly, I was able to return to diving about a month after having COVID, so I'm one of the lucky people. This is some pictures from my first dive back just under a year ago. This is me and my dive buddy up there in the top left. This is how they were running the dive boats back then on the top right in West Palm Beach, where they only had allowed 8 people, 8 divers, and you had to be separated. And that's kind of how we did it. And these are just typical. This is shots from one 2-tank trip in West Palm Beach. So I'll give a selfless plug to my favorite operator down there, which is Pure Vita Divers. If you ever get to Florida and the West Palm area, I'd highly recommend looking them up. So what do we know about COVID? So the background is, and a lot of us know a lot of this by now because everybody's been dealing with this for a year, but the SARS-CoV-2 virus is a coronavirus that causes the disease, and they call it COVID-19 because it was first described in 2019. Coronaviruses are these spherical envelope-positive stranded RNA viruses that have these little crowns, those little things you see there on the right, which is why it's called a coronavirus, for crown. It commonly causes respiratory illnesses in humans and actually makes up about 15 to 30% of the common colds. So there are tons and tons of coronaviruses around. It's just this one happens to be a very bad one. We've had 2 severe outbreaks in the past with coronaviruses. There was the SARS, which is the SARS-CoV-1 virus back in 2002, 2003. And then there was the MERS virus, which is the Middle Eastern variant. The SARS-CoV-1 was this global epidemic that happened back in 2002 and 2003 coming out of China. Luckily, it had very few cases. There's only 8,000 cases worldwide. It did have 774 deaths, which gave it a mortality rate of quite high, 9.6%. The MERS was actually far worse. This was in the Middle East. It was recognized in 2012. It was not very infectious, thankfully. So there were fewer than 2,500 cases, but there were 858 deaths. So the mortality rate from this virus was actually over 1/3. So this was a horrible virus, and thankfully was not very infectious, or this would have been a disaster. So currently, with COVID-19, you guys all remember back in Wuhan City, China, back in December of 2019, there was a cluster of these pneumonia cases that were reported to the World Health Organization. This virus was isolated. They termed it the SARS, just like the original SARS-CoV-1. They named this one SARS-CoV-2. It's sequenced genetically very similar to bat coronaviruses, and obviously it's had worldwide spread. I looked up the numbers as of yesterday, and as of yesterday, there were over 136 million cases worldwide, 31 million in the United States, almost 3 million deaths worldwide, and over 500,000 deaths here in the United States. This has been, as we all know, a major, major problem over the last year. It's spread mainly by large respiratory droplets, so things like coughing, sneezing, speaking, or singing, which is one of the issues with churches, as the main reason this is spread. Also, if you're in crowded places, especially something like bars where people are close together and it's loud, so you're having to speak very loudly, there's also an increased risk of spreading the virus. We used to think that there was a lot of problems with contaminated surfaces. I'm sure you guys remember back in the early days of the pandemic where everyone was having their stuff delivered from Amazon or from the grocery store and leaving it in the garage for 3 days and all this sort of thing. It's currently felt that that's not very common. That can occur, but it's far more likely these are respiratory droplets. And there's also an airborne route with aerosol generating procedures. So for those of us in medicine, things like intubating a patient, doing transesophageal echo or endoscopy, where you can generate these aerosol particles. So what we do is, classically, to get ready to intubate a patient, the anesthesiologist is in this full Mop 4 looking gear. Everyone steps out of the room, the patient's intubated. We then wait several minutes for any aerosol generating kind of particles to fall to the floor, and then everybody comes back in. Actually noticed today, I had my teeth cleaned today, and they used to use the high pressure water jets to clean the plaque. And the last 2 times I've been there, they've gone back old school with just the regular scraping with their tools. And I asked about that, and they said it was the same thing, that because in dental offices, those high velocity jets would generate aerosol particles, and because of COVID, they've kind of moved back to old school here for the time being, at least. So how does this work? This is a picture of an alveoli. We all know about alveoli from overexpansion injuries here in diving. That's an alveoli there on the right. So what happens is this virus will infect the airway cells of the alveoli. That can progress to causing a pneumonia. And in some people, it's very, very mild. Some people develop very severe lung injury. The other problem that can happen is it can break through this and get right into the bloodstream. As we know, the alveoli are these small little air sacs right next to the capillaries. for gas exchange. So if there's any kind of rupture of the alveoli, this viruses can pass directly in the bloodstream, which can cause direct or indirect problems. This is one of the patients at our hospital. This is an elderly man. You can see he would be considered high risk. Those circles you see in the middle of his chest are his sternal wires from his prior coronary artery bypass surgery. You then see the pacemaker generator there in the left upper chest. So he would be high risk. This is his chest x-ray when he showed up in the hospital. The following day, he had the x-ray on the right. And what you'll see is a lot more white areas, more patchy looking areas. And also, if you look right above those circular wires, you'll see a vertical linear line. That's from his endotracheal tube. So he was intubated within 48 hours of admission. Thankfully, this gentleman survived, but he was hospitalized for about a month. The other thing we look at, these are the CAT scans, and I'm going to show you this because we're going to mention some CAT scan things a little bit later. This is a normal looking chest CAT scan here on the left. This is the patient is positioned on their back, with the top being their chest and the lower part being the back, and then the side to side. And this view of a CAT scan is basically like taking someone and slicing them like a loaf of bread. And that's the heart there in the middle. That's the normal lungs that are black, and the little white areas you see are kind of blood vessels. And that's what a normal chest X-ray, or normal chest CT would look like. On the right panel, you see the A, B, and C are various cuts. And this is somebody with very bad COVID pneumonia. And you'll see a lot more of the white patchy areas kind of spread throughout the lungs. And then the bottom panels, the D, E, and F, are reflective of kind of the same kind of views you would have seen on that chest X-ray on the previous slide, with, again, large patchy infiltrates of all those white areas. That's all the COVID pneumonia. And this is a rip-roaring, very just multifocal, multilobular pneumonia that gets people very, very ill. The timeline, in general, the incubation period, which means that you've been infected, but you don't have symptoms. So this is a time frame where you could actually be infecting other people, even though you feel fine, is about 5 days. It can range from anywhere from 2 to 10 days, but the mean is about 5 days. And the initial symptoms, as we all know by now, are kind of fever, cough. People will have loss of smell or taste in about 68% of cases, shortness of breath, rapid breathing, and so forth. And respiratory failure frequently, if it's going to occur, happens about a week or 10 days after symptom onset, but that can be highly variable in various patients. Like I mentioned, it's usually a respiratory illness, but it can affect other vessels or other organ systems. It affects the heart as well. I jokingly say that we charge people in medicine by the length of the names of things, so we try to make them long and complicated. You can get what's called a cardiomyopathy, which is the fancy word for meaning a weakened heart muscle, and that can cause problems with congestive heart failure and fluid buildup. It also can set people up for dangerous heart rhythms. So we have lots of cardiac involvement, and this will come up with our recommendations, kind of the last part of the talk. Additionally, this virus, along with lots of other viruses, can activate your clotting system and cause you to start forming clots around your body. This happens with other viruses like HIV and dengue fever and Ebola. Also happened with the SARS-CoV-1 virus. So these people are at risk for forming clots. Now, back a little less than a year ago, there was a lot of headlines about the very unfortunate Broadway actor who had lost his leg. He was a guy that had this problem. He got very, very ill, clotted off his leg, had to have his leg amputated, and then unfortunately eventually passed away. Otherwise healthy gentleman passed away from the virus. So when you develop these clots, they can form in the arterial system, resulting in strokes, resulting in loss of limbs. We've seen several people at our hospital who've come in with heart attacks in their 30s, who at time of cardiac catheterization always sees a clot in one of their vessels with absolutely no evidence of any kind of cholesterol buildup. You can also get clots in the venous system, the veins. That's just what gives you kind of blood clots in the legs, which can break loose and cause blood clots going to the lungs. It can be a fatal problem as well. These tend to be a little bit later, and we'll talk about that in a few slides when we start talking about therapy and kind of how the timing of where you are in the disease determines what the best mode of therapy is. When this first came out, people said, oh, it's just the flu. You know, this is just like the flu, and why are we getting so excited about this? We have the flu every year. Well, this is clearly not the flu. This is a variety of illnesses on this graph. You see the mortality rate on the y-axis and what's called the basic reproduction number on the x-axis. That basic reproduction number is basically how infectious a particular illness is. And what it stands for is your R0 is basically how many people one person with this disease will usually infect. So you see something like measles and mumps are highly infectious, where one person will routinely infect 11 or 15 other people. Things like the flu are a little over 1. COVID-19 you'll see is kind of in the 2 to 3 range. You'll notice that MERS is less than 1. If you're less than 1, things die out pretty quickly, because if one person's infecting less than one person, that's gonna basically die out. But from the mortality standpoint, on the y-axis, if you blow it up with a little insert graph, you'll see that the mortality for influenza is in general about 0.1%, whereas COVID-19, as best we can tell, and it's highly variable based on age and other medical conditions, is around 3.5%. So this is markedly more deadly than the flu. And like I mentioned, the fatality rate is highly related to age. So if you're very young, the likelihood of dying from this illness is quite low. But once you start getting into 60s, 70s, and definitely over the age of 80, the mortality from this illness is very, very high, which is why we've had the problems in Florida originally with all the nursing homes. And it going rampant through the nursing homes with lots of people dying, same way in New York and other states as well. And why people who are elderly probably should shelter in place and be a lot more conservative than those who are younger in terms of their risk of mortality. So how do we test for this? And this comes up because now we're trying to open up and actually travel. So the usual test involves detection of this nucleic acid by means of what's called a PCR assay. So you'll see you'll need to have a PCR test. This is very highly sensitive just before and soon after symptoms. Its specificity, so its likelihood of being negative if you're healthy, is 100%, so it's very accurate. There is another way of testing, and there's a rapid antigen test that you can just get through a mouth swab or a nasal swab, which is much less invasive, much less uncomfortable. It's also less expensive and gets results very, very quickly within about 15 minutes, but it's not as accurate. And for most countries, if you're traveling, if you look at where you're headed, they'll require a PCR assay. So if you do this rapid test, that won't count, and they won't let you in the country. So that's an important distinction, that you'll need to have a PCR assay, not one of these very rapid antigen tests at the present time. As far as antibodies, the majority of people will develop antibodies within about 14 days. We don't know a lot of what that means, because when you're tested for antibodies, they give you a yes or no. They don't give you a titer. So you don't know if you have a little bit of antibodies or a lot of antibodies. I developed antibodies and I was donating blood. I donate blood anyways every couple of months. And I was in a study where they took my serum and took the antibodies and used it for research. I don't sure exactly how that's going to pan out. We'll talk a little bit about that here in a couple of slides. So currently, we all know we've got travel restrictions still in place, lots of screening, case isolation, contact tracing, quarantines, people taking temperatures, wearing of masks. Unfortunately, wearing of masks has somehow become a political thing and not a medical thing. Social distancing to avoid the transmission. It's felt that usually, if you're just speaking in a normal tone or coughing or sneezing, that the farthest that the virus will transmit will be about 6 feet in the air before it would land on the ground. Hence, that's the reason for the social distancing recommendations of about 6 feet. That's not the same if you're speaking loudly or singing. It would be much farther. And then obviously we've got the vaccines, which we'll talk about. And like Ken mentioned, they just put the Johnson & Johnson vaccine on hold today. The issue is, and this is for the non-medical people in the group, it's not all about just antibodies. Our immune system has two different types of cells. We have what's called B cell immunity, and we have what's called T cell immunity. I don't want to get into too much detail about this, but the bottom line is the B cells are what make plasma cells, which then make antibodies. So if the immunity is for this disease is based on B cell, then antibodies are what we need, and that would be very, very helpful. And then as the antibodies were to wear off, you would then lose protection against the virus. However, what we don't know is if there is a significant T cell immunity to this virus. So if you were infected, even after your antibodies went away, you may still have some memory T cells that can protect you. We just don't have the information for that yet. So just be aware of the fact, the only reason I bring this up is just be aware of the fact that vaccine trials are only measuring antibodies, and there's more to it to our immune system than just antibodies. I'll kind of leave it at that. So the vaccines, as we all know, Pfizer and Moderna were the first ones that came out. They were about 95% effective against the virus. Each of them require 2 doses of vaccine. The Pfizer vaccine is given 3 weeks apart. The Moderna vaccine is given 4 weeks apart. The Johnson & Johnson vaccine, the advantage of that when it came out was it's a single dose. So especially in, maybe not, let's say in the United States, but in other countries where it may be difficult to get people coordinating them back for 2 doses and so forth, it would be very effective there. Its overall efficacy against all forms of disease is lower than Pfizer and Moderna, but it's very effective against severe disease or mortality. So it's very good from that. Unfortunately, if you guys watched the news today, there were 6 cases, all in women, of developing serious blood clots, like I talked about before. They didn't give a lot of other specifics. Now, that's out of millions of dosages, but still, since there was a blip there, they put that vaccine on hold until they've done some further investigation. That may or may not be a long-term problem, or they may release it back into circulation if they feel that really wasn't related to the vaccine. So we'll have to kind of wait and see for that one. But otherwise, the Pfizer and Moderna's vaccines are still are obviously still ongoing. We've heard a lot of news over the last few months about variants, and people are worried about, well, this thing is causing variants, and is that going to mean the vaccines aren't going to work? Well, first of all, we need to realize is, yes, it mutates, but it's actually mutates a lot less than even influenza. If you look at influenza A and influenza B, they mutate a lot. That's why we have to have a different flu shot every year. And actually, this is actually mutating less than the SARS-CoV-1 and the MERS virus we talked about before, but it does mutate. The issue is the vaccines. The difference with the current vaccines is they're not going after the virus itself. They're not an attenuated or a dead virus like some vaccines are. This was basically, it's an mRNA virus, so the vaccine. So what it does is it gets into your system, and the mRNA will cause you to make the spike protein, just those little crowns on the virus. And then your body will develop antibodies to those spike proteins. So if you have any kind of an infection with that spike protein, it will then fight that off. So as long as the variants don't change much with the spike protein, the antibodies will work even against the variants. And that's what we found out. So these are the 3 major variants that have been out so far. This is the South Africa, the Japan/Brazil, and the United Kingdom variants. The first and third have an increased transmissibility. And the UK variant obviously looks to be about 30% more lethal, so it's much more concerning, and that's spreading rapidly. But the good news is the vaccines have been shown to be effective against all of these variants, thankfully. So why should we not worry about the variants? This is what mRNA viruses do. They mutate. That's just part of the way they work. The SARS-CoV-2 doesn't mutate all that fast. It's just being transmitted a lot. And like I said, it actually mutates a lot less than even the common influenza viruses. The neutralizing antibody titer information for the vaccines is reassuring that they still work against these variants. And again, we have this whole issue with the T cell and B cell responses. So we don't really know how much of this is just related to antibodies anyway. So we don't need to get overly concerned. And like I said, all the vaccine trials, even the Johnson & Johnson variant, which was not as effective as the other 2 in general, have been shown to eradicate the severe disease, even with the variants. And because we've got these vaccines and they're against the spike protein, the companies now they have them could easily tweak the vaccines if we needed boosters or whatever, if something were to come up in the future. So I think we're still in good shape with the vaccines that we have. So how do we treat people? And by the way, we're getting to diving here, the next little thing. I'm just going to go through treatment, then we'll talk about how we're going to deal with this with diving. So most people will have no symptoms or very mild symptoms, kind of like what I had. And those people can easily recover at home just with supportive care, some rest and isolation. If you are somebody at high risk for complications, you're elderly, have several comorbidities, it would not be a bad idea to use a pulse oximeter, which you can buy off Amazon, and monitor your oxygen saturations, which should stay, in the mid to upper 90% range. If they start getting close to 90 or lower, that's when you should contact your doctor and probably go to the hospital. So it would just be something for those high-risk people to kind of follow if they were concerned. If you have moderate symptoms, again, monitor even more closely and consider being hospitalized, and then the people with severe symptoms end up getting hospitalized. So how do we treat this? And this, I'm going to go over some of these treatments because they kind of came up with Trump and some other people as to kind of what they received or what they should or shouldn't have received and so forth. So the virus is replicating greatest just before or shortly thereafter when you develop symptoms. So that's when true antiviral therapies are going to be most effective. That would be the remdesivir and antibody-based therapies would be given at that point. The inflammatory state and that coagulopathy where people are forming clots tends to occur later in the disease. So that's going to be a week or 10 days out. And that's when we start using anti-inflammatory medicines, potentially immunomodulators, and true anticoagulants, true blood thinners in kind of that phase of the disease. So of these specific therapies, there was a big push towards chloroquine, hydroxychloroquine. Does this work? Should this be used? And so forth. And what happened was it did show in vitro, that means test tube, kind of activity against the virus. And there was an initial single group observational trial where they just kind of looked at people who took it, and that looked promising. However, when true randomized trials were given, it did not show much of a benefit. So currently it's not recommended to be used outside of clinical trials. Remdesivir, the antiviral agent, did show benefit in hospitalized people with pneumonia. So there is an emergency use authorization for that. So that can be used in people who are hospitalized with severe pneumonia. There's not much data regarding mild or even moderate disease. So it probably should be held up just for those patients who are very, very sick in the hospital. Convalescent plasma, like I was donating for the last 6 months or a year, small randomized trials really haven't shown much of a benefit. A larger expanded access trial showed that if you happen to be getting high titers of the antibodies, you did much better than low titers as you'd expect, and maybe if you get it early in the course. So there is an emergency use authorization for that, but the FDA kind of did emphasize this is not standard of care, and that we need more randomized trials. And then lastly, monoclonal antibodies, there's not a lot of published data yet, but that's also being studied. Steroids, benefits limited to people who are very, very ill and people who are on ventilators. And there may be actual harm if you're not on supplemental oxygen, because you basically with steroids can block your immune response. So if you had mild disease, you could actually make that worse. So it's not recommended for mild or moderate disease. We only give steroids to the sickest people who are on ventilators. And that's what we're going to talk about as far as treatments. This is, I'm sure, the term that nobody wants to hear for the rest of their lives is the term flattening the curve. We heard all that just for months and months and months. And the concept of that was, when this virus started, if we had done nothing, if we just said, to heck with it, we're just going to see what happens, we would have a curve that looks something like that in red, where we'd have a massive number of cases early. Everybody would then either get herd immunity or die. And then we would wipe this out pretty quickly. The problem was we were going to overwhelm the medical system. So if you can imagine a horizontal line, let's say just above that words that say social distancing, that would be like the number of ventilators we had to use. So we'd get into the problem that Italy had early on, which is that all of a sudden we have more people who need ventilators than we have ventilators. And at that point, doctors are going to have to decide who lives and who dies, and nobody wants to be put in that situation. So the idea with flattening the curve wasn't going to change the numbers of people infected. It was to slow that down so we didn't overwhelm the medical system. So as expected, as you lift restrictions, you get waves of disease. But as long as we keep it to the point where we're not overwhelming the medical system, at least from a medical standpoint, that's the safer way to go. So you can make other arguments concerning what it's doing to society and to the economy. Okay. So enough about the virus itself. What about diving? So the common questions that tend to come up for those of us in medicine when it comes to diving with COVID-19 are several. One is, can the virus be spread underwater? Number two, how do we go about disinfecting our gear, especially rental gear if you own a shop and so forth? How do we safely resume diving? What changes do we need to make in dive training? And then I'll finish up with kind of when can someone return to diving safely after they've contracted the disease? So we'll go through these a little bit one at a time. So can the virus be spread underwater? We don't have a lot of data on the SARS-CoV-2 virus, but we do have data on the CoV-1 virus from 2002, 2003. And that showed that basically pools or hot tubs inactivate the virus. So if you are doing training, confined water training and so forth in a pool, that's going to inactivate the virus, and that's not a problem. There is some data, and there's actually data now with CoV-2 as well, that the virus can be infectious for long periods of time in surface water like lakes and rivers. We don't have any data for salt water. It's unlikely that it's going to be infectious enough that because you're sitting on the surface snorkeling that you would get infected, but that's a potential. Salt water, there's no data, but obviously with water movement and the just sheer volume of water in the ocean, that would be very unlikely that you would get infected by that. But just be aware we don't have a lot of data. Disinfecting our gear. The one good thing that's come out of this is I think we've actually gotten much better now as an industry at disinfecting gear. Anybody who's an instructor knows we used to just kind of, in the pool, we'd kind of rinse everything off at the end of the day, stick it up in the rental rack and use it again tomorrow night. We probably should have been better at disinfecting gear all along, but now this has kind of brought this to the forefront. There's actually, the EPA has a list in for a variety of things. This talks about all kinds of disinfectants, what they've been tested against, what they're effective against, what concentration you need, and how much contact time you need. So it's a great resource. I looked through that and just kind of pulled out some things, kind of common disinfectants to kind of show you what will work against the COVID-19 virus. There are two types of maticide, maticide 1 and maticide FD that are effective. There are a huge number of simple green products, but the two that work against the COVID-19 virus are Simple Green D Pro 5, and there's a spray bottle of the Simple Green Clean Finish that works very well. For anybody out there who's rebreather divers, Vircon S, which we use a lot used to use a lot for rebreather diving for cleaning out loops and so forth, has been shown to be effective. Stearamine, which is actually probably one of the most common things used now for disinfecting rebreathers, is not on the list in. Not because it's ineffective, it just hasn't been tested, or at least wasn't tested the last time I checked. They may be getting it tested any time, but just be aware that there are certain products that are useful, other ones that have not been tested. If you happen to be a dive professional and you have gear that's being used by multiple people, I would strongly recommend looking at this list in or using one of these products to disinfect the gear. You can always use bleach. Bleach is very effective, but it's also very toxic. You basically, if you want to use that, it's 1/3 of a cup and 1 gallon of water, and it requires a contact time only of 1 minute. With all of these products, you've got to just kind of rinse them and let them dry, and you've got to be careful not to reinfect the gear. So as you can imagine, if Jimmy, your equipment guy, is cleaning everything and he's infected and he rinses everything off, and as he's getting ready to hang it up, he coughs onto his hand, grabs the gear and puts it back on the shelf, you've just now reinfected everything. So you got to be careful of all that. Okay, how do we safely resume diving? For dive centers, we basically have to socially distance. So you end up with fewer students in the classroom, fewer students in the pool. Obviously, things like this with Zoom and so forth, so there's more online training. So lots of online training has been growing a lot over the last year. And the other thing to be aware of in a shop is things that are touched by your customers are going to need to be re-sterilized. I mean, if people want to buy a mask, they're going to try it on. So they may try on multiple masks, put them on their face, their nose. Don't let them put them back on the shelf. Those need to be kept aside and then sterilized before putting back. Dive charters, this is kind of how things went in Florida and kind of how they've been going since the pandemic. Face masks are required for all crew and all guests. We have fewer divers on boats. They've opened it up to about 50% or so, but it started out, like I said, very, very few. You'd have like 8 on a boat that would hold 25 or 30. So fewer divers on boats. There's no more common mask buckets, so you don't rinse your mask in a common mask bucket. Divers tend to be required to wear masks on their face and regulators in their mouth when they're getting away from their spot and going into the water, or from when they get out of the water till they get back to their spot. They can take their mask and regulator off, then have to put a face mask covering back on after that. And then to avoid everybody touching things, what we do in Florida, and Kid and I were talking, sounds like what they did in the liveaboard in Socorro he was on, is staff get all the snacks, drinks, and so forth for customers, so you don't have multiple people touching things like the coolers and water jugs and snacks and so forth. From a training standpoint, the one issue that we really have with training is going to be the out of air drill, because there you're going to be passing, classically you'd pass, say, your primary to another diver, a simulated out of air diver, and how are you going to do that in these days of COVID-19? So all of the agencies have kind of looked into this, and they have their own kind of way they've altered this drill. But in general, what most of them are doing is something like the following, where the donor will pass their primary or their alternate to an out-of-air diver. That diver will then hold that regulator in their hand. They do not put it in their mouth, but they will switch to their own alternate just to get the muscle memory of the skill, but try to protect against infection. Obviously, this is not ideal, but it's the best we have in the current situation. Obviously, in the pool, we just said that the pool, will kill everything. So you could go ahead and do the drill in the pool, but we're trying to make sure people do things the same way in the pool that they would do in open water. So we're going to train them in the pool the way we would do it in open water. So that's kind of how we've been doing it, which is pass the primary, have the donor, the recipient hold that, and then switch to their own alternate, and then switch out. And again, not ideal, but that's the one main issue we have with training. How about travel? The world is slowly opening up. I've had 2 overseas trips since I had one in November and one in December. November I went to St. Lucia, and in December I went to Cozumel. The travel restrictions vary by country, and not only do they vary by country, but they vary by day. So you got to keep an eye on this. If you're going through a travel agent or a shop, they'll keep track of this for you, but just be aware that things are changing very, very quickly. Obviously, some borders like the Caymans still remain completely closed. Many countries, most countries, not Mexico, but most countries require a negative test to get into the country. Some countries require a quarantine, and that can be easy or hard. You may be required to be in a government hotel for a week or 2, which obviously is going to screw up your entire vacation. When we went to St. Lucia, we were technically quarantined to the resort, but we weren't leaving the resort anyway, so it didn't really matter. We went from the airport to the hotel. We stayed on the resort property for the week. That just meant we didn't have any little tours, into the island. And then we flew out the end of the trip. So that worked for us. Obviously, now over the last few months, the USA is now requiring a negative test within 3 days to re-enter the country. So a lot of places are trying to figure out how they're going to do that. You can get tested. A lot of places, the resorts will bring in somebody to do the test 2 or 3 days before people are due to leave. So again, it's a little bit of a hassle, but if you really want to travel, it's worth it. The other issue to take into consideration, which people haven't talked a lot about, though, is that even if you're healthy as you leave the United States, we know there's that 5-day quarantine or 5-day incubation period. So you can be infected but still feeling well. And even though there are good places, to dive, there's some of those great places aren't really good to get sick. So you wouldn't want to be feeling healthy and then realize you're sick as you land in Jakarta. That would be a problem. So that needs to kind of go into your thought process a little bit as well. Not just how am I feeling, but if God forbid I'm incubated and I'm going to get sick 2 or 3 days from now, where am I going to be 2 or 3 days from now? And what is the medical care going to be like where I am? So this comes right out of Alert Diver magazine. Basically, if you're going to travel, you should ask yourself the following questions. First, is travel safe, responsible, and permitted between where I live and where I'm going? Secondly, would some sort of a quarantine, like a 2-week quarantine, be required at the start or end of the trip? And how is that going to work with my job and my family life to accommodate that? Would I need to get tested upon my return? And then is that possible? And how's that going to work? And then what's going to happen when I get to a destination? Places are still closed. So what am I going to need to bring in terms of things like hand sanitizer, snacks, water, and so forth? What health services are available when I get there? So if I do get sick, what options am I going to have? Does my medical insurance cover illness abroad, or do I need to get a special COVID kind of coverage? And what happens if I can't fly home because of illness or because of border closings? And what's that going to do to the cost of the trip? What's that going to do to my job situation? What's that going to do to my home life? And then along the lines we talked about before about disinfecting gear. I think everybody should own their own gear, but some people, travel and then rent gear. This may be a reason not to do that. Maybe you should have your own gear when you go. So general principles, obviously try to stay healthy and fit. Don't dive if you're sick. Practice good hygiene. Maintain, disinfect your gear. Heed travel warnings. Obey local orders and manage your risk. This, by the way, obeying local orders. You probably guys have heard about the girl that got put in jail in the Caymans because she was supposed to be quarantined and she went up to watch her boyfriend race some jet skis and they threw her in jail. And that's clearly in their right. And she knew that was the order when she got there and disobeyed it. So make sure you know what the local policies are wherever you're traveling. So before you go, realize that a lot of travel insurance does not cover pandemics and viruses. So read the fine print. In some situations, you may have to get a secondary policy to cover COVID-19 if you want to do that. I don't know if anybody's been at airports recently, but airports look a lot different than they looked before the pandemic. Don't plan on finding a lot of restaurants open. Don't plan on finding a lot of snack places open. So you're going to want to bring your own drinks and snacks. You're going to need to arrive early because getting through security may take longer because they have fewer people working. And obviously, masks are mandatory unless you're eating or drinking. There's not much in the way of snacks or meals on planes anymore. And the other thing to be aware of, not just are masks mandatory, but they can't be the kind of masks that have the one-way valve. So you've seen the sniffer masks have a little valve on them. That will keep you from getting infected because it's a one-way valve. It lets gas out but not in. So it makes it easier for you to breathe through the mask, but it also is not as safe for your fellow passengers. So the airlines will not allow you to use that as your mask on the plane. You'll either have to wear something else or wear something over the top of that. So just be aware of that, as not all masks are created equal. What about liveaboards? Ken I've not been on liveaboard since this, but Ken has, he could address this. But where should I go to minimize health risks? One question is how many flights is it going to take to your liveaboard? If you're flying to Hawaii for a liveaboard or to Cayman for a liveaboard, that may be easy as a one-stop trip. But if you're going to have to make 4 or 5 connections to get to some liveaboard in Raja Ampat, that's going to expose you to multiple flights and multiple airports with lots of people. So that's probably going to be a higher risk situation, which I'm not saying you don't do, but just needs to be kind of put into your mind as to your risks and benefits and what are you willing to do. You need to ask your operator, how are they cleaning and sanitizing their boats? You got to figure out how you can maintain social distancing on board. Ken was telling me right before this that they serve meals at different times, and then they kind of went to an upstairs, downstairs kind of thing to get people fed. So that'll work. Some liveaboards are having fewer guests on board, and some of the companies have actually decreased the single supplement so that divers don't have to share cabins with people they don't know. They're just trying to fill their boats and get some business. They're willing to cut you some slack. What happens if you start showing some symptoms before you paid for this $10,000 vacation? Please don't go. Operators are much more flexible these days regarding cancellations and rebookings because they don't want their customers getting sick either. So please cancel. Don't take any chances. You can always rebook it. And like I said, most of the operators are very, very forgiving with that sort of thing. I can put this in a PDF and give it to Ken if people want it, but these are all the places to go to for all these travel restrictions. So if you want to look for travel restrictions, you go to covid19.state.gov. You can also register your trip with the Department of State. There's some general travel advisories here, and there's a bunch of updates on various restrictions on the PADI website, scubadiving.com website, and the DAN website. So all those are good places to go if you're planning on traveling abroad to get the latest information. Okay. The last little section is probably the most important for most of us who have experienced this. And the question then is, can we return to diving after COVID-19? And if so, how do we do it? The problem came up last spring when a very well-meaning physician in Austria by the name of Dr. Hartig, who is a physician and a diver, published his experience in a magazine called Wet Notes, which is a diving publication. It's not a medical journal. And this article was then posted on Facebook and went absolutely viral.
Well, if it's on Facebook, it must be true, right, Doug?
Yeah, exactly. We're going to getting to that. One of my recommendations is going to be to get your medical advice from physicians and well-respected places, not from social media. But so he reported on 6 non-hospitalized divers out of what he said were, quote, dozens of COVID-19 patients that he had treated. All these patients felt well 6 weeks after their symptom resolution. But when he tested them, 2 of them showed hypoxia, which is low oxygen levels in their blood when they were put on exercise on a stress test. 2 of them demonstrated reactive airway disease, which would be basically asthma. And 4 showed what he considered, quote, impressive lung changes on CAT scans, like those CAT scans I showed you earlier in the talk. And his conclusion was that these divers had, quote, irreversible lung damage, and these divers would never be able to dive again. Now, I'm hoping that was taken out of context and the way it was translated from German to English was incorrect, because I don't think any respectable person would say that based on 6 weeks after a serious pneumonia that you're going to say things are irreversible. We know lung damage can take a while to recover, and saying people will never be able to dive again is probably definitely overstating things. But the problem was this went viral, and a lot of us in the diving medicine realm got just inundated with questions and concerns and so forth, to the point where the UHMS actually had to publish on their website the following statement. They had to say, at the present time, we do not have sufficient data to support or refute the proclamations made by the case series from Dr. Hartig. The list of potential variables related to how this disease manifests, its clinical course, and long-term prognosis is lengthy and may include factors such as underlying medical conditions, age, disease severity, and secondary complications. Case reports, which is what this was. This wasn't a formal, double-blind, randomized, placebo-controlled trial. So case reports suffer from multiple design weaknesses to include a lack of controls, a lack of randomization, which makes any conclusions that we may want to generalize to a larger population suspect. And then finally, they came up with a statement that while these findings are indeed disquieting, it will take time before the potential impact on individual health and any lasting effects or on lung or heart function are captured in the peer-reviewed, meaning the medical literature. So basically they said, yes, this is interesting, but please don't read too much into this. So the question is, okay, we have those 6 patients. What data do we have? We don't have a lot of data yet on COVID-19, but we do have data on the SARS-CoV-1 virus from 2002, 2003. So this is the data on residual lung disease from that virus, which is very similar. This was reported in the European Respiratory Journal in 2004. There's the reference if anybody needs it. They looked at 46 survivors of SARS 3 months after hospital discharge. So these are all people who have been sick enough to be in the hospital. They gave them 3 months to recover, then they looked at them. They found that half of the patients had absolutely no abnormalities whatsoever on pulmonary function testing. That was 23 of the 46. In the other 23, they did see some findings, and these acronyms you see down there are just basic parameters that we study in respiratory and pulmonary function testing. So they saw some people had some abnormal lung volumes and so forth. But the key was all of these were mild except for one case. So out of 46 people, 23 had nothing. Additional 22 people had mild findings, and only one person had something other than mild. So it was very, very rare. So you're looking at one case out of 46. That's just a little bit over 2%. So very, very unlikely that very many people are going to be permanently disabled from this disease. So when can someone safely return to diving after contracting COVID-19? This is my bias as of today. Like I was hinting at earlier, first and foremost, get your diving information and recommendations from organizations like DAN, Undersea Hyperbaric Medical Society, or the South Pacific Underwater Medical Society, and not from social media like Facebook. Secondly, just like every disease, this is not going to be a one-size-fits-all scenario. Take the example of diabetes, take the example of asthma. In the past, we used to say that no one with diabetes, no one with asthma should dive. That has all changed. And now we know that a large number of people with diabetes and a large number of people with asthma can dive safely. Now, there are clearly some diabetics and there's clearly some asthmatics who should never dive, but that's a small number of people. And probably COVID-19 is going to be the same thing, which is that the vast majority of people are going to be able to return to diving. Now, there will definitely be a few people here and there that have such severe disease that they have permanent damage and they may never be able to return to diving. But that's going to be a very, very small number of people. The signs and symptoms of the disease are highly variable among patients. This, I think, is very important. I think divers need to first at least have returned to a normal level of fitness before they even consider going back to diving. Like I mentioned in my own personal case, was getting back to the gym or getting back on the rowing machine. Now, that assumes that the diver had an exercise regimen before the illness. And I've been telling divers and students for decades that you don't dive to get in shape. If you're getting in shape by diving, you're doing it wrong, right? I mean, it shouldn't be that much of a demanding sport. So you should exercise and get in shape to dive, not the other way around. So hopefully divers have a normal level based on a fitness that they're aware of. So if they were to get sick, they should get back to that normal level of exercise they were doing prior to their illness before they even consider returning to diving. And then if people have more than just minimal disease, they probably should be evaluated by a physician knowledgeable in diving medicine before returning to diving. This is probably the best approach we have while we wait further data. And just be aware of the fact that Dan does have a study to follow divers. I'm actually in that study who've contracted the disease. So if you're interested, you can email them at medic@dan.org. It's basically an online survey. They ask you questions, and then every couple of months, they send you another email and just going to ask how you're doing. It's very easy, and hopefully we'll generate some data that'll be very helpful for the diving community. Now, that having been said, there have been some recommendations that come out. I was involved in a paper which we've submitted It was myself, a PhD, a critical care and pulmonary doc, and an ER doc and a radiologist who looked through all the data that we had and tried to come up with a recommendation as to when people should return to diving. The people at UC San Diego have done the same thing, and they're almost identical. And there have been some scientific diving organizations have also come up, and they're all pretty much almost exactly the same. So I'm going to give you those kind of in closing statements as to kind of how we think divers can get back to diving at the present time. So here are the guidelines. It's divided into 4 categories: 0, 1, 2, and 3. Category 0 is people that had no symptoms. So these are people that they had no known disease, but for some reason they got a screening test that was positive, or they got tested and were found to have antibodies, but they never had any symptoms. Those people really require nothing. Unless there's something, and if they're a professional diver and some group requires them to have something, from a medical standpoint, they probably need nothing. And if they are at their level, normal level of exercise, they can return to diving with no testing whatsoever. So that's easy. If people have mild disease, which would be people like myself who kind of felt bad at home for a few days, they did not require oxygen, they did not require going to the hospital. It was all just done as an outpatient. And if they had a chest x-ray, which I did, it was normal. These are people who would be considered to have mild disease. So these people can return to diving. They probably should have some assessment of their lungs because they did have some mild disease. So spirometry, which is actually a very easy test, and a chest x-ray is probably all they need. If the chest x-ray were to be abnormal, then we should move on to something like a chest CAT scan. And if the exercise tolerance was poor, they should probably at that point get an exercise tolerance test, or if they just didn't ever exercise, just to kind of get an idea of what their exercise ability is before you allow them to get back in the water. So something simple like spirometry and a chest x-ray is pretty much all they need. If they say they were jogging 2 miles a day before all this, they're back to jogging 2 miles a day, they don't need an exercise test or anything else. They've kind of given you that their exercise tolerance is back to normal. More moderate disease, so category 2, these would be people who were sick. These are people who have been in the hospital. They required some additional oxygen. They had an abnormal chest x-ray or CAT scan. They're admitted to the hospital, but they didn't require being intubated, being put on a ventilator, or didn't require oxygen like BiPAP or CPAP or going to an ICU. So those people would be considered moderate disease. These people require a little bit more workup. They again would require the spirometry and chest x-ray. Again, if abnormal, the CAT scan. We know that once you have that kind of at least moderate disease, there can be cardiac involvement. So it's recommended those people have an electrocardiogram and probably an echocardiogram, which is an ultrasound test of the heart to make sure their heart muscle functions okay before returning to diving. And again, the same caveat about exercise. If they were already exercising and they're back to that level of fitness, you're probably fine without an exercise test. If they don't have very good exercise tolerance or it's unknown, then you probably should do an exercise tolerance test with some oxygen saturation. I didn't mention that in my own finding, but I did mention to you that I'd gotten back on my rowing machine and felt fine. And then what I did before I went diving was I stayed after work one day. We obviously have treadmills at my office, and I put myself in a treadmill with an oxygen, with a pulse ox on my finger, and made sure I could jog for 10 or 15 minutes without my oxygen saturation dropping. So at that point, I got back to diving. Finally, these are the people that you're most concerned about. These people have with severe diseases, a very, very small percentage of people with this illness. These are people who ended up in the ICU and were either intubated or required BiPAP or CPAP for oxygenation. These people also may have had cardiac involvement with an abnormal EKG or some elevated biomarkers like troponins and so forth. Or they may have had these complications of coagulopathy where they had a blood clot in their leg or in their lungs or some other coagulopathy. So people who are very, very ill, these people would require a significant workup before returning to diving. Would probably need to be out of the water at least several months before you even consider letting them get back in the water. And they would again need the typical spirometry, chest x-ray, if abnormal, go to a CAT scan, EKG. If they had elevated biomarkers or elevated cardiac enzymes, which happen in about a third to a half of people with severe disease, you'd want to make sure those had gone back to normal so there wasn't any active sign of ongoing inflammation of the heart. You'd then want to get an echo and ultrasound to make sure their heart muscle function was normal. And then you'd want to get an exercise test with oxygen saturation to make sure that they weren't desaturating with exercise. So again, as you can see, we broke it down to 4 categories: no symptoms, mild, moderate, or severe symptoms. And the worse your symptoms were with the disease, the more evaluation that you need. But the vast majority of people are probably going to have nothing or maybe just a chest x-ray and some spirometry. So in conclusion, as we wrap up, and it's about 11:30 or about 8:30 your time, COVID-19 is a coronavirus. It's a serious illness with a mortality rate that's about tenfold that of seasonal flu. Most people have no or very mild symptoms, but a small percentage of people will get very sick and even die, as we know. It's spread mainly by respiratory droplets. So to decrease the spread, we do things like social distancing and wearing masks. Obviously, the elderly and high-risk patients have very high mortality should they get this. So those people should shelter in place as much as possible. And again, as restrictions have been lifted, there's been an expected increase in the number of cases. Individual divers, dive shops, dive charters, and training agencies all need to adapt, like we talked about. And when considering dive travel, consider your medical care and your return travel options should you get sick on vacation. Like we mentioned, there's a lot of great places to dive. They're not great places to get sick. And then as far as returning to diving after infection, this should be possible for almost all divers. The divers will need to be asymptomatic and return to their baseline level of fitness. And then if they had mild or more disease, they should be evaluated by a physician knowledgeable in diving medicine to decide if further testing is needed before returning to diving. The best way to do that is to contact Dan and have them put you in contact with somebody with knowledge of diving medicine who's in your area to kind of help coordinate that. And that's everything. So I'm open to questions if anybody has anything.
Well, cool. So why don't you lose the share screen if you would, Doug?
Yep.
And then usually the way we work the questions, first of all, everybody can give Doug a nice round of quiet applause if you want, or unmute and stuff. But usually the way we're working the questions is if you can find the raise hand icon on the little Zoom thing, go ahead and do that. Carol's always been very good at that. She's probably been the best. Or just actually physically raise your hand, and I'll try to sort of call on people so we can maintain some level of order. But Carl Huggins has his hand up first. He's got to be an overachiever. So Carl, and it was funny when I saw your background at first, Carl. I don't have my contacts in, so I thought it was a purple coronavirus. Now I realize it's just a bunch of bees.
One bee with the flower.
There you go. All right, Carl. For those of you who don't know, Carl is the director of the Catalina Hyperbaric Chamber. Did I mention Chamber Day is May 5th? Go ahead.
So one of the things that I've heard of, because I've dealt with one of my crew members, is this long haulers syndrome that seems to present itself like chronic fatigue syndrome for people who've had and seem to recover, but then sort of slid back into this level of chronic fatigue. Do you have any idea what percent of the population? This was somebody who was not hospitalized, but treated at home, didn't require supplemental oxygen, but still ended up with sort of this long haulers problem.
Right. There's the number of patients of that is small. It does happen, and it's significant for those people. I can't give you an actual number, but what I can tell you is I know one of our physicians at our clinic. I'm in a clinic that's about 250 docs, about 1,200 or so employees. One of our docs has started a long haulers clinic. So our population is about 100,000 people, and we've got about a draw of about 500,000 into our area. And her clinic has about 40 or 50 people in it after a year of this. So, that's out of thousands and thousands and thousands of cases locally. We have 30 or 40 probably that are long haulers. And again, like you mentioned, it's kind of a chronic fatigue syndrome, and that's really difficult, to sort out, Epstein-Barr virus, chronic fatigue. Some of these things the vast majority are real. Some of them are probably not real. So it's really hard to sort all that out. The treatment for that is difficult, and it's mainly just based on symptoms. So whatever you can do to kind of make their symptoms better, and you hope they get better. But there have been people definitely that have continued symptoms and problems with the illness, for months at a time. And luckily, it's a very, very small percentage of people. But that's the best I can give you on a number. I've not seen a published number on that.
We've got a question from the chat from Vic, who I'll mention is also a doctor, and he wondered what you think of vaccine passports, especially when it comes to liveaboards.
I think that's going to have to decide. I think it's a good idea. If you can prove you've been vaccinated, it's you're probably far less likely to get infected or infect someone else. That's going to be political, I'm sure. Actually, there's places now that are, there's already people who are selling fake vaccine passports on the internet. I saw a report where they were going anywhere from like $50 to $500, kind of thing for these things. If anybody here on the call has been vaccinated, it's not anything formal. It's just a little card. You write your name on it and they stamp it. So it'd be very easy to fake it. So, and if they could come out with a much more secure way of doing it that still maintains privacy, because that's the other issue, is the whole HIPAA thing with privacy. It's a good idea. I mean, I think in general, if you can prove people have been vaccinated, that will markedly decrease the likelihood of them becoming infected or infecting somebody else. So that would be very, very helpful. But the devil's going to be in the details between how to make it accurate and how to make it not have a problem with privacy laws.
Well, and especially too, and Doug and I were talking about this a little bit ahead of time, and this is just my opinion. And to be clear, I'm not a doctor, but I have played one on TV.
Yeah,
that's true.
very good.
But on a boat, like I was on the Nautilus Undersea in January, and we had protocols we went through and testing beforehand. But on a boat, you're basically in a contained system there. And on the one hand, if you know that not a single person on the boat has COVID, then there's no way for anyone to get sick on the boat, and you could dispense with all the various mitigation measures. On the other hand, if you do have someone on a boat that is sick, there's a good chance they're going to infect everybody, because no matter how much you try to social distance, it's going to be relatively close quarters. So I mean, I think these are going to be things you may see, and some people are going to object to that, and it gets back down to balancing the right of privacy against what's your right to infect other people with a disease that could potentially, depending on age and other underlying factors, prove fatal or certainly very complicating. So no easy answers. What other questions we got?
Hey, I have a question. I tried to raise my hand,
Brett.
but it didn't work. Hey, Ken, how are you? Doug, it's good to see you. The last time I saw you was Little Cayman for the Inner Space, I think in 2019.
Right. And 2020 got delayed to November, and then delayed to May, and now is canceled.
Yeah, exactly. But Little Cayman was pretty awesome. But I'm curious. I know we're obviously both technical divers, and I know another person or two that are technical divers that have had COVID. And I know Dan's doing an ongoing study, but did you adjust your RMV or SAC rate calculations after you had COVID? I mean, it's because I do know somebody who had, he's a reasonably accomplished technical diver, and he had COVID and he had asthma before and he has asthma now, but he's adjusted his RMV calculations for bailout.
What I did on my diving was I like to be conservative. So when I said that when I first got back to diving, I did a nice simple drift dive in West Palm Beach with a buddy who had been healthy, and he knew I'd been sick. So I said, we're going to take it easy. When I first got back into cave diving, I took a nice, easy mainline kind of intro kind of thing, and I purposely bailed out from about 1,500 feet back and checked my SAC rate. So I actually did a bailout on purpose, and my SAC rate was unchanged. But I didn't really expect it to be different because, again, I had already exercised on a treadmill with a pulse ox. It was fine. But I did go ahead and check that. So I think it's a very good idea because this is a respiratory disease, that if you're going to get back into something that's going to require deco and so forth, you should check those sorts of things and be just extra conservative with your gas planning and build yourself up. Do simple stuff. I was telling Ken before, I ended up doing about 130 dives last year. This year so far, I've done about 40. And that's been everywhere from, deep wreck technical stuff to ice diving to teaching cave classes to whatever. So I'm one of the fortunate ones, but not everybody's that lucky. But yeah, I would definitely recommend people be conservative in getting themselves back to that kind of whatever they're doing before. Take it easy and build yourself back up slowly, and verify everything as you build yourself back up. Very good point.
And
yeah,
for
sure.
for those of you going, SAC rate, what the hell is a SAC?
Oh, sorry.
Surface air consumption. Well,
Sorry,
no, it's
surface air
good though,
consumption.
because I'm thinking it's a Nowie versus Patty thing, because now he's real big on surface air consumption rate. So anyhow,
Yeah, they're different.
that's what it is.
Yeah, it's a little bit different. Rest of minute ventilation and volumes and so forth versus seconds. But the idea is basically how much gas would you use?
Yeah.
And in things like we were talking, where you're on rebreathers, if the rebreather craps out on you, you need to have enough bailout open circuit gas to get from wherever you are to the surface safely. So and you calculate those things. So again, if you calculate them incorrectly, you find out in a very bad way that you don't have enough gas with you. So always good to do that. Sorry about that. I didn't. You know, we
Yeah,
should have
no,
That's
talked a
okay.
little more
That's
about
okay.
that.
I'm just thinking, even for non-technical divers, I mean, you might find, like, if you're just diving in AL 80 on a recreational dive and you've had COVID, you know, your AL 80 might last half the time it would normally last if your breathing isn't back to normal.
Right. But again, my recommendation is make sure you don't go back to diving until your breathing's back to normal.
Yeah. But people might not know, like you said. I mean, if they're not exercising regularly. So I just wonder what your experience was specifically. And I agree to obviously to building back up. I haven't had COVID, luckily. But you know, it's I think short term, it's bound to change your respiratory rate.
Oh, absolutely. Like I told you, I thought I was well, and within 5 minutes rather than 30 minutes on a rowing machine, I was totally out of gas. So
exactly.
if I'd gone diving at that point, I would have been sucking through a tank for sure.
Yeah, and just to be clear, guys, they have these little things called gauges that you can monitor during your dive. So we recommend them highly. And Brett, I see your note in the chat about not knowing how to raise your hand. You can always go old school and just go. We recognize that as well. Annette, I see you're unmuted. Do you want to ask your question yourself, or you want me to read it from the chat?
Well, either way, you know.
Go ahead, ask it yourself.
Well, I have to, you know, the CDC last summer, you know, indicated, and we've talked about tonight, that there's extremely remote chance of getting COVID from surfaces. And what we've seen is there have been articles in places like the New York or New York Times that talked about the hygiene theater. And I've noticed that my dive boat, I'm here in Maui, so I get to dive, shore dive. I am so friggin' lucky all the time. But I've noticed that the boats are, you know, burdened. And we talked today about, you know, are you going to get COVID from like sharing regulators, you know, safety procedures underwater? And yet, even without the intervening thing like water, the chances of getting COVID from contact is so remote that, I mean, don't you think that this whole hygiene theater contributes to this kind of hysteria, which is not productive? So,
yes, it's become political, as you're kind of hinting at. So yeah, I mean, the fact that boats have to kind of wipe everything down, and to be honest with you, you know, if you're cruising along at 20 knots, you really think you're going to get a virus from somebody who's standing 4 feet away from you when you're not wearing a mask? It's going to blow right past everybody. So a lot of this is overkill. As an example, for the last year, every time I've walked into the hospital, I've had my temperature checked. Yesterday, I asked one of the people who checks the temperature, how many people have had an abnormal temperature since you've been doing this for the last year? They've had no one. Okay, so it is entirely, it's to look good on paper. You know, every time I walk into my clinic, people go around taking your temperature. They've never had one abnormal at our hospital or at our clinic in a year, but they do it all the time. So yes, it's overkill. Masks have become politicized as well. What I say about masks are, you know, is wearing a mask going to keep me safer? Maybe. Is wearing a mask going to keep someone else safer? Maybe. Okay, this is a potentially life-threatening illness, so for me, maybe it's good enough. It's not. I mean, I wear a mask all day anyway in the OR, so what's the big deal to me? So again, I agree with you entirely. Which a lot of this has probably been blown out of proportion and has become more political than it has medical, and probably has resulted in some of this hysteria, especially the surface kind of stuff. I think that's definitely been kind of over dramatized as to what the risks are really for getting something off the surface of a dive boat where they have to wipe things down when everybody's in the water, hose the whole boat down and wipe it all down again before they get back on the boat and all that sort of thing.
Yeah. Well, my view is, you know, the respiratory droplets piece of it, masks make some sense, and staying away 6 feet makes some sense.
Right.
That makes some sense. The rest of it is all hysteria.
No, I agree with you entirely.
Well,
I mean,
I think the temperature taking is probably a valuable thing, and I understand that. But the rest of it is all hysteria, and given the remote possibility that you're going to, transfer this virus via surfaces, is so small. I mean, it's just so friggin' small. Anyway,
I agree.
I'm on my little high horse here.
Yeah, that's okay. I agree. I mean, you're right. The counter argument is every little bit helps, but you're right. You got to draw a line between what's practical and what's really kind of getting kind of silly. Carl raised his hand again. I think Carl has a comment.
And we got two ahead of Carl. Unless
Okay.
it's a direct comment on Annette, Carl.
Yeah, it's just from what I've heard and seen in terms of the influenza rates last year, whatever the techniques that have been used helped reduce the amount of influenza last year.
Absolutely. Yeah, our influenza are definitely down this year compared to last year and the year before.
It's almost like washing your hands and stuff really works. What an amazing thing.
Yeah, and if you're wearing a mask, the likelihood of developing respiratory illnesses is lower.
Yeah.
That makes sense.
Bob Sanders has his hand up. Bob, you're up.
Excellent. Thank you. And it's been a while, Doug. Good to see you again. I wanted to kind of chime in on the lung injury because we've had 10 cases in our divers at NASA, and one of them has had significantly persistent lung injury. Now, when you brought up your statistics and talked about the different measurements, the one thing that wasn't included was the mid-flows, so the FEF, the 25 to 75% range. And that's where we have seen significant injury, and actually people down to about 30% of what's expected range. And that is what carries some risk in situations where we have gas expansion, so rapid ascent, stuff like that. If you're diving safely and normally and moving slowly, likely it wouldn't be a problem, but in contingency situations. So we do advocate, as you had mentioned, the pulmonary functions, the spirometry in everyone. But even for people who may feel completely normal, and in this particular case, we do have a diver who can exercise. He hasn't noticed any change in his exercise tolerance. He has been very active, runs, lifts weights, all of that, but does have significant persistent lung injury. So it's something where it's 6 weeks now, and he's still showing the injury. We're hoping within 3 to 6 months he'll recover.
But just out of curiosity, does he drop his stats with exercise?
No.
So it's only just the mid flows. Because again, I didn't mention mid-flows specifically because in that study that I showed you that was done in the European Respiratory Journal about SARS, they didn't report that. But when we get spirometry, that's one of the indices that gets measured, obviously. So,
and that's just something where I've also seen lung injury in divers from any acute situation. Someone who was out filming the fires in California came back and had persistent lung injury, and that's really where we saw it. So, I advocate for anyone if you've had COVID, definitely the pulmonary functions, and look for normal in all of your numbers, even if your doctors aren't comfortable with mid flows.
And for those of you who were not on our December Zoom call and are going, who does this Sanders guy think he is? He's the medical director for NASA for the Neutral Buoyancy Lab in Houston. But Bob, so let me give you a related question. Have you guys, or how have you guys changed your procedures because you're dealing with astronauts who probably don't want to get COVID up at the space station?
So I love it. When there was the discussion about temperature checks, because I've asked the same question. We've done 25,000 screenings. Actually, we're probably closer to 28,000 now, coming into the NBL, and we've taken temperatures on every single one of them, and have never, just like you all, had an abnormal temperature. But in addition to the temperature check, we ask the screening questions, and we have had about, I think, 25 times where people have come in with active illness, and we have caught it in the screening. So while the temperature check doesn't do any good, if we actually stop and ask the questions about overall health, we are doing better. So we have stopped all tours in our facility. We have minimized bodies. So if you can telework, we have people teleworking to get the number of people in the NBL down to about half what it normally is. We don't do our morning physical exams in bulk with the astronauts. We have them in a separate room to decrease the exposure. Normally there'd be 25 people in a room that's about it's maybe 10 by 10, 10 by 20. So a very small room, and we just have people cycle through it. So we're not doing that anymore. Then amongst the others that would be in close proximity to the astronauts, we've stopped. We used to have communal food. We've decreased the numbers in the mission control room. So really taken a lot of aggressive moves there. Then also very aggressive with vaccination and the encouragement of vaccination.
Very good. Okay, Glenn, you've got your hand up. You're up.
So those of us who have already been vaccinated, I guess it's sort of the Wild West. Nobody knows anything, how long a vaccination will keep us safe. But I'm anxious to get back in the water. Most of us have not been in the water for a year, and I have, for one, have been staying in place for pretty much a year. So I'm just now went to the gym, started going to the gym, and have to do that. But everybody's rusty on their skills, it seems.
Absolutely. I was actually talking to the training director of one of the dive agencies on a Zoom call about something else yesterday. And he is an instructor, trainer on a variety of rebreathers, but hasn't been in the water in like 8 months. So he's thinking he probably needs, despite the fact that he's an instructor, trainer on multiple units, probably needs to do a refresher before he goes back to rebreather diving. So, I mean, I think from a recreational standpoint, you know, the agencies usually recommend that people haven't been in the water for 6 months to do a refresher. So even people who've done hundreds or thousands of dives, if they've been out of the water for a year, probably not a bad idea to do a refresher before you go back in the water that first time.
Dan Orr has his hand up, and I believe he's written a little article about this.
About that, probably
yeah,
so.
Which for the record, we had the link in Twarz the other week.
I do appreciate that. Yeah, I just finished writing an article for, actually it was in Dive Newswire on skill degradation. And it was actually, I looked at a number of different things that were complex psychomotor skills, like the kinds of skills we use in, especially emergency situations. And that was in Dive Newswire, and then you put a link in your newsletter also. So I appreciate that. Because some of those skills actually degraded in as little as a month.
Well, and the other thing to remember, and it goes back to the lack of diving thing, also, there's a good chance, you know, we've all put on that pandemic 10 that you have not been working out if you do work out. So not only have you not been diving, but probably just your general physical level, even if you've not been sick, is not anywhere near where it was a year ago. So again, factor that in as well.
Absolutely.
Any other questions? As I'm looking around.
Oh, I see a hand.
Lars, are you waving, or is that your hand up to ask a question?
Dan, how you doing, Ken?
Good. How are you?
Good. So I just got back from Cozumel on Saturday, and a couple of interesting points. One being that the Midwest and East Coast airports that I went through were completely open. All the restaurants in those airports. I mean, everybody's wearing masks as the federal guidelines recommend, but they were pretty open. One interesting thing in Cozumel that I didn't mention on our regular club meeting earlier was they still have mask rinse buckets on those boats, which I don't ever use anyway because, you know, I don't want to catch what the next guy had in their mask. And also they're still using the way they rinse gear afterwards, basically a communal tub, you know, where everybody puts their regs and BCs and everything else into. So some things, although they're making a lot of strides to wear masks and keep people separate, and the food is probably a lot more cared for as far as cleanliness and how all of that is, there's certain things that ironically have not changed. And I was on probably 4 or 5 different dive boats while I was there, and they were all the same. So kind of an interesting perspective on that. And all the flights were full, you know, there wasn't a seat open. So that might've been the scariest tin can ride, I guess. of the whole thing. And on the dive boats, it was, not a full capacity. So just food for thought.
And I'll tell you, the flip side of that is I've been talking with a friend of mine in Bonaire, and I just got a note today on Facebook from Sally Warman, who's in Curacao right now. And both of those, Bonaire right now, they've both seen a resurgence. Bonaire's on a total lockdown. Curacao is pretty much too, where if you're at a resort, they'll let you dive from the resort, but that's about it. Bonaire's limiting resorts just to filling tanks, no boat dives, no rental gear, stuff like that. So sort of to go back to Doug's original point in that red curve that went way up, at some point, you got to be careful. You're going to get a little resurgence as you lift the restrictions, and you want to make sure you don't overwhelm whatever medical facilities you have. And in places like Bonaire and Curacao, rather meager.
Yeah, really good point. One other little thing. Last year I was ill, didn't get a COVID test, but the people around me who got much more ill and ended up in the hospital even tested positive. And I can say that that I had weird headaches and symptoms that went on for weeks afterwards that couldn't really pinpoint or identify as to what, it's not like you felt ill, like you couldn't get up, but you just had like unusual symptoms that you just don't have in your normal life. So certainly I can talk to some people who may have had recurring and long-term. When this all started, everybody was like, oh, months later, you still weren't feeling right. It must be something else wrong with you. And until you get sick yourself, and I had mild symptoms, you, in hindsight, look at it quite differently. So I guess, and I was exhausted too in some times. I had no way I would have gone around the block happily, much less going diving. So anyway.
Glenn, did I forget to put your hand down, or do you have a second question?
I have a second question. So I guess the takeaway is that we all have different risk aversions, depending on what our perceived health issues are. And in terms of diving, that just complicates the problem. And like traveling, yeah.
Right. Everyone has to decide what their own risk tolerance is, just like with everything else in life. Some people won't fly, period, because they're scared of flying, whatever. Based on your age, your comorbidities, your risk aversion, some people may not dive. Some people may be willing to fly to Raja Ampat. It's an individual. Thank God we have freedoms and people can make those decisions. So the key is realize that you want to make sure your personal decisions aren't adversely affecting someone else if you can all avoid it. So you're allowed to get yourself drunk if you want at home, but you're not allowed to drink and drive. Okay, so you don't have to wear a mask at home, but you may have to wear a mask to fly. So if you're not going to wear a mask, then don't fly. But if you're willing to wear a mask, you can fly. That sort of thing. So that's kind of how to look at all those things.
Any other questions? Or shall we make that the final note?
Well, I'd just like to make a final comment.
Sure.
And say thank you very much. This is probably the most informative presentation I've seen of anything on COVID, and I really appreciate it.
Oh, thank you very much.
Very good.
Thank you, Doug.
You can all unmute.
Great job.
You can do that.
Great job, Doug.
Give some actual
job.
applause. So thank you, Doug, very much. And don't forget, he's in Florida, so it is now past midnight. So technically, this was a 2-day presentation. Technically.
Multi-day presentation.
Yeah, there you go. Next month, we've got, I think it's Danny Charlton from Murex in Indonesia. We'll talk about diving Indonesia, and we'll talk about if Indonesia's even open, and we can get to it. Just remind you, if you want to revisit any of this, the recording will be on Facebook. It'll be up on our website. If you have any questions, you can shoot me a question. I can forward stuff to Doug. But thank you very much, Doug. A very informative presentation. I think it's got a lot of people thinking about stuff and a lot of nice comments in the chat section. So Thank you for spending the time and giving everyone something to think about.
Thank you so much. I appreciate it. You guys have a good night.
Well done.
All right, guys,
Take
with
care.
that note,
Thank
I'm
you,
going to
Doug.
exercise my
Bye-bye.
power as the host of this meeting to click among my favorite buttons if they go too long, which is end meeting for all.
Yeah.
Thank you, guys.
Permission,
Bye-bye.
Thank you very
permission to
much.
sleep another hour tomorrow, Doug.
There we go.
Okay.
Bye-bye, everybody.
Bye now.
Bye.